Hello friends, this is Dr. Samin Afzal Junajo from Hyderabad, Sindh, Pakistan. Friends, in this video I will show you the significance of the equatorial approach during the phacoemulsification process when we come across a soft cataract and a bowl is formed, and then how can we get rid of such a horrible situation and save the posterior capsular rent and other complications. Now in this case we are creating a 5 to 5.5 millimeter wide anterior capsular axis by using a needle cystotome through the surgical limbal approach. A round, regular, curvilinear capsulorhexis has been formed and the needle cystotome is removed. Through the cystotome port, we will inject the OVD dispersive deep in the anterior chamber, and the intraocular pressure is maintained in order to facilitate the formation of a full thickness limbal corneal incision through diamond knife, which has been made. Anterior chamber is still deepened and the intraocular pressure is maintained. The eye is not at the state of hypotony and we are very comfortably creating two side pores at 3 o'clock and at 8 o'clock in the opposite directions. As I have told you before that there are many advantages of two side ports. They can facilitate the aspiration of the cortical material which is stuck up at 6 o'clock and 12 o'clock. The side ports can negate the astigmatism against the rule, and the side ports also help maintain the intraocular temperature towards the cooler side during the process of phacoemulsification and release of phacoenergy due to the continuous irrigation of warm fluid from the side ports. Hydrodissection and delineation has been done and the process of phacoemulsification has been started, and I am making a central trench. As we can see that the nucleus of this patient is a soft nucleus of not more than grade 2. The patient is young and during the phacoemulsification the pupil is a bit constricted, might be due to the excessive release of prostaglandins E2 from iris stroma due to manipulation. Even in spite of a very good hydrodissection and delineation, the nucleus is adherent to the posterior capsule and it is not coming out. I am rather struggling to take the bowel nucleus out of the bag, but gone failure. Now I will again inject the viscoelastic solution and I will try to do the visco dissection, because my effort has not been successful to remove the nucleus, which is a bowl nucleus, from the bag of posterior capsule. After doing the visco dissection, now again with a ringer solution I will perform the hydrodissection and delineation once again, and I will wait a couple of minutes, maybe 1 or 2 minutes, and again start doing the phacoemulsification and under the vacuum without applying a phaco energy. With the help of a side chopper I will try to take the nucleus out. I am trying to pull it and the nucleus is still quite adherent and the pupil is becoming smaller and smaller. Ultimately I decided to catch hold of the equator. I pushed the center of the nucleus down towards 6 o'clock and caught hold of the equator of the nucleus, and as I grasped the equator of the nucleus is immediately out of the bag. The equatorial approach is the best possible solution in the cases when a bowl nucleus is formed or when the nucleus is quite adherent and not leaving the bag. Equatorial approach is a quite safe procedure by which we can save the time and complete the phacoemulsification without causing any injury or tear, rent to the posterior capsule. And now the Simcoe irrigation and aspiration cannula is being used to remove the cortical matter from inside the bag. And whenever I feel like removing the cortical matter from the 12 o'clock position or 6 o'clock position, I will again take the help of the side ports. Now I will inject the viscoelastic solution and try to aspirate the part of the epinucleus and cortex from the main incision . The pupil is myosed . Maybe because of a little bit repeated manipulation by the phaco handpiece. A foldable hydrophobic IQ intraocular lens is being implanted in the bag in presence of OVD dispersive. And now I will remove the viscoelastic solution from the anterior surface of the lens, going a bit behind the optical zone of the lens. Remove the cortical matter behind the lens in order to prevent the postoperative induced myopia, refractive surprise, cellular reaction, and transient rise of intraocular pressure. And then at the end I have given the cocktail injection of antibiotic, pilocarpine and dexamethasone. Thank you very much.